not too many years ago, was a fellow in our program and now very successful allergist at Northwest Asthma and Allergy, and also leading the research over there. Changed the name some years ago from Asthma Inc., since there's not much asthma research anymore, to Seattle Asthma Allergy Research. Kindly is going to give us an update on all the studies that are going on over there. And I've got some peripheral involvement, and I can tell you there's some really brilliant stuff that he's brought in here, cutting edge, and it's going to be a sort of fun story to hear about what's going on. So Dan, thank you.
Thanks, Lynn. So as Lynn said, my name is Dan Petroni, and I took over the research at Seattle Allergy Research back in 2018. Here we go. Let's go to my disclosure slide. Here's my disclosures. I'm a consultant for Hollister, and I'm on the ad board for Takeda and speaker bureau for AstraZeneca. So the word of the day is vineyard. And if you like wine, there is a Petroni winery over in Sonoma, and it's really good wine down there. It's not my family, but it's a very distant relation of my grandfather. But they've been around down there, and they have a lovely restaurant in San Francisco called North Beach Restaurant, which is fantastic. The founder has passed away, but his son runs all the business now. All right, so let's get into it. So as I said, as Len said, we have changed our name a couple years back, and now we're Sorry, as opposed to Asthma Inc. And big mission is to continue bringing cutting edge research, as Len said, and continue to enhance our local partnership with scientists at University of Washington, Benaroya, and all sorts of collaborators out there. If you want to know what's happening, this is the best place to go, seattleallergy.org. And then if you have any patients who are interested, they can go to our login to get our research database, which is a survey. I've now kind of well over 1,500. Last time I checked, it was almost 2,000 at this point in our research database. And ask you all about whether you have hives, food allergy, asthma, all the different typical kind of allergic diseases that we are investigating. So collaboration. So CFAC. So CFAC has gone through many iterations. So those of you who don't know, CFAC was set up about 8 years ago, I think. And it was a collaboration between UW, Children's, Northwest, and Asthma Inc. at the time, as well as VM and Benaroya. And originally, kind of like the guiding members were Bill Henderson, Mary Farrington, Suzanne Scott-Smith, and then we've had lots of retirements over the last bunch of years, and so it's kind of whittled down quite a bit. And so there was debate of whether we need to stop or we can revamp and renew. So coming in this fall, I'm going to request a meeting with kind of the new representatives of all the major groups around here, because it's all new blood, to kind of come together and have a new collaborative effort. And so we'll see. So there's a lot of new faculty members who are joining other places, like later new fellows who are joining up, and so to get some new collaborative efforts going forward. Other collaborations that have come to forth has been us getting into the GI field. And so I couldn't have done that without Dr. Bernstein at Puget Sound Gastro Health. And he's been a sub-investigator on all our GI-related studies. And we'll talk about some of those later on today. All right, so let's get into the big area of research that we're doing right now. It's in the clinical food allergy research, and also some updates of like what the clinical versions of the application of this that are happening locally. So the problem, estimates of 15 million Americans have true food allergy, 4% of adults, 8% of kids. Enormous increase from the 90s to the early 2000s and to the mid 2000s. And it's not just us. Europeans and Australians have very similar incidences. And of course, the top allergens that we are all aware of: milk, egg, peanut, tree nuts, wheat, soy, fish, and shellfish. And then milk and eggs are taking much longer to resolve. On average, natural outgrowth for those are around 15 years of age now. Estimated costs around $25 billion annually. Locally, in 2006, we had about At Northwest Asthma and Allergy, about 4,200 visits related to food allergy, about a third of the diagnosis codes for all office visits. 2017, 12,000, which was over 60% of all office visits. So it's something that really is impacting kind of us locally, as along with the world, the developed world in general. And this is kind of the respective visits for all the different kind of food allergies that we have and the respective increases of them. Oops. Okay, so these are the food allergy treatments investigation in the area. So oral immunotherapy, both clinical and investigational, biologic therapies, gene therapy, prevention, as well as epicutaneous immunotherapy. I have some updates about that too. So we've been involved with the peanut OIT since the first pivotal trial that came out with ARCO-3, and then the kind of the rollover, which is ARCO-4. This all started around 2013, 2014, and then the safety trial. There is an ongoing ARC trial, which is 05, which is the Poseidon trial. This is the toddler peanut OIT trial. They took a long time, but they finally closed their enrollment. And then the rollover maintenance study for extended treatment, and that's called ARCO-8, and that's all coming to an end very soon. So Palfordia, or AR101, which was the research name, was approved in the FDA by the FDA in early 2020. Pandemic, of course, delayed implementation. And at Northwest Asthma and Allergy, we're starting to roll it out and explore how it can be integrated. I've had over 5 years experience with this product, so I just wanted to kind of once again kind of tell you my experience with it and kind of my approach of how to do kind of this type of OIT, which is the FDA approved version of it. So you got to pick the right candidates, and you have to be very open with patients about this. So many of the families, when I kind of present the schedule of events, kind of bow out at this point. So it's very important to discuss that this is a major time suck that they're going to have to put a lot of effort into it. So they have to have Q2 week visits for 5 to 7 months that last anywhere between an hour and a half to 2 hours each. The patient needs to be an easygoing, flexible time schedule, wants to participate. That's a very important thing because they're going to have to do this every day. Compliant to the dosing regime and restriction activities. So that is one of the most important aspects of this. So the activity and reactions post-activity, which is exercise or especially kind of like competitive or high intensity practices, you can't, this is not really compatible with taking it before any of those events. It has to be done afterwards. And so with some of the club sport athletic kids, they are practice in the morning, practice in the afternoon, and then all the way into the evening. There's no real time for them to kind of integrate this. The restriction of time is anywhere between 3 to 4 hours after you dose, taking one of the OITs for the entire duration of taking it. And that's the only time I've ever seen severe reactions has been take a dose of OIT and then immediately or soon thereof have exercise. One of the more concerning events was this young man that was at a camp out in the Olympic Peninsula. He took his dose and then immediately went on a run in camp. And he had been on immunotherapy for like a year and a half, and then had a severe anaphylactic reaction out in the middle of nowhere. The camp counselors had no idea what to do. I was being relayed. They called me. I was relayed from my cell phone, through the parent's cell phone, through the cell phone of the child at the site. The only person who stood up and actually took responsibility was the kid himself, who emptied himself because nobody else was comfortable doing it, and then had to get emergency evacuated over to a hospital soon after. So it's very important that they understand this. So you're adjusting your life around this. So this doesn't make your life easier. It makes it more complicated, and you have to really think about this. And it's for the duration of time that you're on it. So really understand, the families need to understand that, and then so they can go in with eyes open. So poor candidates are people who with extreme anxiety related to their allergy. This will not make it better. It can oftentimes make it worse. I've had to send some children over to counselors and therapists because the OIT was just panicking them. And so at the first beginning, it tends to be a little bit worse. And then, as I said, the anxiety does not get better when they're on therapy. And then unable to follow the dosing regime or the restrictions because of either time away from school or the other restrictions. So generally speaking, I like the younger children. So like the 5, 6, 7, 8, 9-year-olds, great. School just doesn't really matter. They're usually not in hyper competitive, and having some time away is not that big of a deal. So I talked about the OIT restrictions and exercise. Those are the big things, right? And those are things that you do definitely have to share with people if you're going to embark on this. So how I approach confirming the allergy. So I only do formal OIT on patients with confirmed history of peanut allergy, clear clinical history, or challenge approved. I will not do this on anybody who just has a positive test. So a testing that was done just because of eczema or just because of some sort of family concern, but no actual positive challenge history, I do not think it is correct to do this because you have not confirmed the allergy. As we all know, a skin prick test or a blood test in the absence of a clinical history is about 50%. So it's as good as a coin flip. And a coin flip is not good enough for me to say that somebody needs to be on this therapy for many, many months to come. So if no clinical history, then I'll do an open label, low dose challenges with very liberal stopping criteria. They don't need anaphylaxis. And so this is the same stuff we do to get people into challenges all the time. And so I'll start at 1 milligram and work our way up from there. And just classic kind of COFAR related kind of stopping criteria and challenge schedule. And if they do really well, so say they react at above like a peanut equivalent of peanut, but they react at 2 peanuts, well, they're already up and beyond the tolerance that would have given them if they were to do Palfordia. So Palfordia only goes up to 300 milligrams. So it's good to know how much they can tolerate. This is a huge spectrum. There's some people who will anaphylaxis at 5 peanuts. That's not a good person for Palfordia, but there's some people who react at like 10 milligrams. Perfect candidate for Palfordia. So it's all up to it's important to kind of confirm the diagnosis, also to confirm their sensitivity as well. All right. So the initial dose escalation day, this is when you first start Palfordia, this is kind of to set up the kind of safety margin. And you start up with starting at 0.5 milligram, 1 milligram, 1.5 milligrams, 3 milligrams, 6 milligrams every 20 minutes with a total cumulative dose of 12 milligrams. And then you give them a 3 milligram dosing pack, and that's what they take daily at home. This is the day that you're going to expect the most frequent reactions. Typically, it's pretty mild, relatively speaking. Most people are not that exquisitely allergic at that level. But if they are, then they're not the best candidate. If they react at like 1 milligram, doing daily 3 milligrams is not really safe for them. So they would be a candidate for other things. So treatment is always symptom-based, H1H2s to epinephrine. I don't think I've ever taken about 70 to 100 kids through this, and I don't think we've ever given epinephrine for initial dose escalation day. Okay, so UpDosing visits. This is an important component that you need to make sure everything is going okay. So what their current state of health at that moment in time, so any fever or illness the last couple of days, date of the last dose of OIT, this is important in case they take it in the morning. So you want to make sure they didn't take it that morning, so you're not double dosing that day. And then compliance checking to see how many doses they've missed over the past 2 weeks. If they've missed more than they've taken, then that's not a time to updose. And then if they have any reactions to it. So generally speaking, if there's any sort of like immediate reactions, I'm not updosing. So if they had any incidents of associated with the Palfordia of high swelling, any sort of like immediate stuff, I'm not going to updose. We're going to kind of hold steady. And if it's really bad, like anaphylaxis, then we might even back down. Delayed stuff, so GERD, dysphagia, food regurgitation, early satiety are all things you need to kind of watch out for. If it's a temporary thing, so sometimes you'll see that at the beginning of an updose and then get better as they go forward, which is all right. But oftentimes I'll have them treat with like like a Pepsid or an antacid to kind of help with the symptoms. But if they're having these symptoms more often than not, then what I'll do sometimes is either stay the course, stay the same dose, or even lower the dose for them. But if it's a persistent thing, it could be EOE, and that's something I'll talk about in the next slide. And then quality of life. This is very important to, so how long does it take for you to eat your OIT? If they say it takes me a minute, fine. If it takes you an hour, well, let's address what's happening, why that is occurring. Do you dislike the taste? Can we change the medium? Can we change other things? And so just yesterday, I was in one of the clinical trials. I had young lady who told me that they took well over an hour to eat their dose. Well, we have to address that. Is it because they are feeling like the tightness down their throat, they can't have swallowing difficulties, or is it just because they hate the taste? Then what are the things that we can do to kind of make the taste better for them or mask it better for them? Usually kind of the basic mediums that you start with is applesauce or chocolate pudding because you mix it in with it. But you can do other things like yogurt can be done. And if you're really desperate, ice cream can be done too. All sorts of things to kind of help get this down. And how do you feel about taking it every day? So I have this handout that I give each one of my, every patient who comes in, and it has these questions in a very simple format, and then kind of like a unhappy to a smiley face kind of emoji based thing to say if they are happy about doing this. And so reactions to UpDosing in the office tend to be GI related. So I've never seen an anaphylaxis to it because if you do all this stuff and ask the question correctly, you can kind of guide and whether or not you actually have reactions based on the person has been reacting the last couple of weeks and you don't ask these questions, then you're going to have problems in the office. But if you do it right, not a problem. EOE and OIT. So it happens in about 5.3% and to 5.7% of the population gets OIT. This is data from a paper that Jonathan Spergel and myself wrote a couple of years ago, looking at kind of all of the studies put together and looking at the average rate of EOE with biopsy confirmed versions of it. And then the AR101 trials had a similar type of kind of biopsy confirmed. I would say on average about 10 to 15% will discontinue because of intractable GI symptoms where you just cannot get them over the hump. And our suspicion is that it's probably EOE-like disease or EOE-triggered disease that gets better when you stop it, and that's the good thing, is that it gets better when you stop it. And this can happen at any time. So it can happen during buildup, it can happen on maintenance, it can happen years into maintenance. So it's something that you have to be vigilant. So even after they get to maintenance, it's something you still have to kind of check in with them and follow. They can't just be left to their own devices to make sure that this is not a problem, okay? So before you guys send all your patients to me for to start Palfordia.
And before you go on, can I ask you a question?
Of course, Lynn.
Yeah. So obviously, incorporation of this into treatment was, quite delayed or totally stopped by the pandemic. Beyond your experience, what do you know about either the regional use of this or the national use of this? How successful has this been overall as a therapy? How widely incorporated is it in practices all around the country?
I don't know around the country, but I know regionally it's pretty limited. There's not very many people that are doing this. As far as I'm aware, there's maybe one or two practices that are doing this, and Northwest included. So, but before you send all your patients to it, we have a pretty extensive waiting list. So if you send anybody brand new to us, I'm telling them a minimum of a year or two before we can get to them, because we have like hundreds and hundreds of patients in our own practice that are doing this. So don't expect it to happen anytime soon. Just send it over. Yeah,
Dan, this is David Jung.
Hey, David.
Hey. So it's a great info so far. I just to answer your question, Len, as far as I'm aware, we're probably the only other site enrolled in REMS. It's not being used hardly at all, and for a lot of the reasons that Dan said. And I would add one more, which is that many of the children that we take care of have multiple food allergies. So when you present this type of treatment option to parents and they ask, how is this going to improve my life? It's going to make it harder, but what is it going to do for my, kids' 10 other food allergies? The answer is nothing. And so that's another very common reason that people turn this down at this point, is because you can't really drastically change lifestyle by addressing one of many food allergies.
Precisely.
Yeah,
There's a common question that gets asked: will this help my cashew allergy? And the answer is absolutely not.
Is insurance paying for this, Dan? Or
Yeah, actually, coverage has been okay. They've had about 2 years now to kind of go through it with insurance companies, so that's actually been surprisingly been okay. Even the more restrictive insurances have become open to it, so that has not been an issue. It's more logistics that have been the biggest challenge of actually getting the product sent to you by the specialty pharmacies, and that's been the biggest hurdle for us. Is just working with them to actually get the product over to us in a timely and efficient manner. And that's the thing. Most of us who do allergy immunotherapy basically build it ourselves, and we have a complete control over that. And so most of us are pretty type A when it comes to immunotherapy. So relying on a specialty pharmacy to send you stuff and control your supply is rather frustrating, to say the least. Something I've had a communication with AIMMUNE is that I think it should be something that we should buy and bill, and that we should have a refrigerator full of all the doses, and we should be able to directly bill insurances for the dosing that we're giving. So we have complete control. So I can go up, I can go down, I can go sideways, I can do whatever I want without having to rely on shipment. And so that's a lot of stuff has to be shipped out to you. And I don't know if anybody else experiences, but shipping has been a little bit questionable, to say the least, and delays. So especially with a product that must be refrigerated. So it's not like something that you can go just pick up at the regular old pharmacy. It's something that has to be shipped and in like cold storage. All right, to that end of the multi-food thing. So we're doing a phase 2 trial right now, which is the Harmony trial, which is a multi-food trial that has all the top 9 food allergens all in one. So it's not a customized OIT, it's like an all together OIT. So it's one size kind of fits all. So it has all the different things. They allowed up to 5 different food allergies simultaneously to participate in this trial. And so it's fully enrolled at this point. We have, I forget exactly how many we have, I think about 12, 13 patients kind of in it at this moment in time, at various stages kind of doing it. And there are some of them actually have completed their initial study and are in the open label component called Encore. Another trial that AIMMUNE had run was the egg trial, and with actually amazing results, but it was killed because of the pandemic, and it doesn't seem like Nestle, AIMMUNE is interested in resuming this one. But I saw some dramatic improvements with my patients who were on actual treatment with that, and they're living a much better life. And so things like egg and milk, I think, would be a much fruitful thing, even with monotherapy, because that can really change somebody's lives. Being able to eat a peanut or tolerate exposure to a peanut when you have 5 other allergies, I agree, it's not going to be that significantly different in your life. But being able to eat egg and milk, which is in so many different things, it's huge. So I'm hoping that more companies kind of focus in on those things, since it's such a life-changing operation. And that's in the Alladapt. Alladapt has both egg and milk in it, a wheat. So Epicutaneous, some updates to this. So our involvement, we've been involved with since the phase 2 trial with Vipes, and then Papeets and People, which was their pivotal phase 3 Realize. And then right now we're actively doing the Epitope Epipex trial, which is the toddler, and Epitope is almost done. So with data analysis to come soon after that, and hopefully some positive results, they'll find out in the next couple of months. So you might hear some things about this. And then the milk patch trial, which was Miles in phase 2 completed, that has not gone anywhere because of some issues with the trial. So as discussed last year, the BLA was denied by the FDA, and the primary concern was related to adhesion of the patch and its contribution to its efficacy. And so they're revamping, retooling, and so they're going to be starting up very soon. We're going to be starting up very soon a new peanut trial called Evolve. And Evolve is simply a trial to investigate how to get these patches to adhere better. They have a new process to do this, and so we're going to be recruiting 4 to 11-year-olds to participate in this and just go through the treatment and make sure that it can be tolerated in the new form that it will be in. No challenges required. So if you know anybody who would be interested, direct them to our website or give me an email. And then they're going to do a new pivotal peanut patch trial. So they're going to actually redo Pepites, and that's going to be starting later this year. It wasn't possible for them to go back and use the old data, so they're just going to redo the whole thing over again. So later this year, there's going to be second version of the peanut patch trial, hopefully with better results. Okay, so ligolizumab and food allergy. So one of the things we that's been done over the last bunch of years has been using of anti-IgE molecules in the treatment of food allergy, mostly for safety induction of food allergy. So pre-treatment with Xolair for a couple of months, usually 2 or 3 months, and then starting of OIT. There's been some thought about, well, what if we don't do the OIT component and we just do the anti-IgE? And there is a trial for that for Xolair that's happening with COFAR. So the first part of the COFAR study is a kind of like monotherapy versus placebo of just Xolair to see what the changes of people's tolerance of their food allergy are. Well, Novartis has decided to do the same thing, but with their next generation anti-IgE, which is ligolizumab. And so this is we just started up the study, and it's ongoing recruitment right now. So specifically, they want just peanut allergics, but eventually, I think they're going to go for the indication to have all food allergics be able to do this. And so I think it's a very different approach. We'll see if it works. Essentially, the first portion of the study is going to be ligolizumab versus placebo, and there's going to be a peanut challenge at the beginning, and then I think it's 2-3 months later they're going to do a peanut challenge, compare what their if there's improvement of their tolerance and their dose, their chemoreactive dose, and then there's an open label for the rest of the year with a kind of challenge at the end. So it's a really it's a very nice study where we're going to look at it both, not just the short term, which is what most of the studies have focused on, but actually looking at it long term and see if there's durability, which I quite frankly don't know if that's going to change, whether it trends down, trends up, whatever is going to occur. But it's as I said, open to enrollment for 12 years and older. And it's been actually a quite popular study because a lot of people like it because they don't have to do the OIT component and they can potentially have something to improve their peanut allergy. Okay, so some updates to the non-OIT versions of things. So Astellas and the peanut vaccine. So this was the LAMP vaccine, double-stranded DNA with the RH2 kind of gene integrated into this in circular DNA. Actually, the tech is not too dissimilar from the mRNA technology for the vaccines. They did a phase 1B for both adult and adolescent. While it was safe, it didn't work. One of the interesting things is that I never saw a significant immune response to this. And for dramatic contrast to like all the mRNA vaccines, which everybody felt, none of them really had significant adverse events to the injection itself or had any sort of kind of typical T1 immune response. So I'm not surprised they didn't do it, but that's been discontinued. The core study, the CMP201, which is a nanoparticle peanut immunotherapy. We did a lot of the preclinical work at both at Benaroya, and then we participated locally in that work, and one of the fellows, now attending, Clint Dunn, worked on this while he was at Benaroya. So the basic principle of this is that because of the setup of their proprietary technology, it's supposed to induce a T1 response and T regulatory response to potentially delete the Th2 cells that are particular for peanut. And it's in phase 1. It's still ongoing right now. It's a hard sell for people because it's an IV. There's problems with reactivity to things, but it's an exciting approach because they're looking more for curative rather than desensitization. So it's really novel. I think we're going to get our first patient into this relatively soon. So a very brave person. So I'm appreciative of them.
Hey, Dan.
Yeah.
This is David again.
Yeah.
I apologize if there's a echo. I have a couple crazy kids behind me, but my kids. But anyway, we're running this core study as well.
Yeah. Oh, that's right.
The phase 1 is on hold.
Yeah. Well, the infusions are on hold. Yes.
I don't know if you said that or not.
The infusions are on hold right now while they're figuring out how to take care of the infusion reactions. Screening is still open. So
already.
Yeah, so it's being worked on because people have had reactions, which is not dissimilar to some of the stuff that we had seen kind of in the preclinical work. So
yeah, we enrolled subjects and had those reactions in our site. So yeah. They're not fun, but yeah, you're right. They're trying to figure out. It seems like they're thinking that might be a non-IgE mediated mast cell degranulation type response. Which is interesting, which is independent of whether it's an allergy.
Yeah, hopefully pre-treatment of steroids. It seems to, at least the preclinical with the bat, it seemed to activate them. So, so maybe pre-treatment will be helpful if it's non-specific. But we'll see. We'll see. Yes, screening is still available, but the actual treatment is on hold for right now. But I'm hopeful that they'll have like a protocol for us going forward. The next kind of big area is prevention. So one of a new company has started up, and they're working on infant gut microbiome based biotherapeutic to help prevent food allergies. This is actively recruiting right now. The FDA has wanted a couple of phases to it, and so they've gone through part A1, which was, and we participated in, which is the 1 year to 6 year old, which was like a safety, just to give it to them for a month to see how they do. Then part A2 it's actively enrolling right now. It's 1 month to 1 year olds who have a family member with allergies, just to see if it's safe. And part B is where they're actually going to do the preliminary safety trial, where they're going to give this to neonates. So within the first 1 day of life is to get them, that's the goal, to get them started on this. And with the primary endpoints is reduction and compared to placebo of allergic diseases at various stages of life. So to see if there's reduction in atopic dermatitis, food allergy, allergic rhinitis, asthma, all that good stuff. So we'll see how that goes.
And Dan, question, I don't understand. What's the biotherapeutic product?
It's a microbiome. It's a probiotic.
With a certain formulation, or?
Mm-hmm. Yeah, so their own kind of formulation. So it's a live probiotic that they're giving to babies, which is very common. Probiotics are in lots of infant formula, but this is something that they think will specifically help with food allergies or allergies in general. Yeah. So we'll see. So far, so good.
Dan, this is Vinod here. Sorry.
Hey, Vinod.
Hey, thank you. It's been amazing, update, and thank you for all the work you do. I know there was something similar to like fecal, oral fecal transplant, or in the form of capsules, that was talked about at the Quad AI. Is it something similar you're talking about with this oral, microbiome therapy?
Well, it's I guess it would be a very specific bacteria that they're using as their live product. Of course, this is all proprietary. They won't tell us exactly what's in it, but it's basically gut microbiome that I'm sure that they've think that will be inhibitory to the kind of allergic processes. There's some speculation about all that. And one of the frustrating things I've always had with people giving microbiome talks is that they've never actually been available to anybody. So they state that this is so helpful to X, Y, and Z, but never actually have it available. If you ask the question, so where can I get this material? What do I tell my patients? You can't get it, it's all proprietary. So hopefully this will be something that will become clinically available if it proves fruitful. But this will be a new way for us to investigate this. I have some collaborators who are pediatricians to get these kind of brand new babies because it's going to be difficult to recruit post-fact. So this will all be like pre-screened with pregnant women and starting soon after delivery.
And while you're on this general topic, as a little bit of segue, all the tremendous work that went into LEAP and LEAP On, as a researcher and the pediatric allergist originally trained, how widely incorporated has that been? Did it just be a flash in the pan, or is
No,
it
I would say completely the opposite. It's really kind of penetrated into the pediatric spectrum. So most of the patients that I'm seeing these days are having reactions because if they're being seen by us, are having reactions because their pediatrician told them to introduce. And so they're actually having positive reactions, or they're like they gave them and have something on the face that occurred. So I'm actually seeing people coming in, babies coming in because of the exposure reactions, and that's all being advised and directed by the pediatricians. Because we can't really capture those kids, because most of the time it's all after the fact, is by the time we see them. And we try to do the introduction to the other foods besides the one that they're reacted to. There is some, some pediatricians out there are still kind of like on the old mentality, and you can, and you sometimes will see the people who never introduce anything, but I've been seeing more and more, and I would say the vast majority are being recommended to be introduced at the very least peanut at around that age. So it's all based off of LEAP. But I remember when I did the first talks about LEAP when I was a fellow and then going forward, the first time I gave a talk about it, it was met with open hostility from pediatricians. It was quite startling that the fact that anybody could ever suggest that you would ever give an infant who was like 4 to 6 years of age food of that type. It made absolutely no sense to them. And then it eventually, over the course of several years, got better and better and better, at least locally, and my experience. So one of the best comments I got was from this older pediatrician who said, I've been to your talk 3 times. The first time, I ignored you. The second time, I heard you, but I decided not to do it. Third time, I'm going to do it. So it's fruitful, and I think it's gotten into the AAP and the kind of guidelines. So it is definitely not a flash in the pan. It is something that is being integrated into practice, and hopefully to great benefit.
Thanks.
Yeah. Oh, apologies, Cialto, not Stialto. Thank you, Dr. Carr. I misspelled. Okay. All right, eosinophilic esophagitis. This is some early phase 2 data about EOE and dupilumab. So we were doing the EOE DUPI trial ourselves, and with collaboration of Dr. Bernstein, and which showed when you were dosing it weekly, there was a significant decrease in both the number of eosinophils in the tissue as well as symptoms. The phase 3 data just kind of came out, so they did a late breaking abstract at the Quad AI, and they found that indeed, and this showed to be true, where people had significant improvement of their symptoms. So not just pathology and not just the path improved, but just also their symptoms improved. So 64% versus 41% in the placebo group. And then 60% showed histological disease remission as well, whereas only 6% in the placebo group did. And then biweekly dosing, because that's what this trial was, biweekly versus weekly versus placebos, showed improvement histologically, but not with patient symptoms. And so Our patient was the last patient in the Part B trial, and he has completed, and so he's in the kind of the safety window. So data analysis should be coming. So at least from the top line data that was presented, it looks very positive. So this could be one of the first therapies that are going to be out where we can actively treat EOE. Anecdotally, from my patient, when he was on open label, it was like night and day. His symptoms improved dramatically with a guy who was having crazy and they had to be off of their swallow steroids, they had to be off of everything else. And on being off of that, he did so much better, even with the Dupixent. So I have high hopes that the full analysis of the data will come to fruition, and then we'll have an actual therapy for patients with this condition, because it's overtly frustrating. I know many allergists out there, it's hard to take care of EOE because, like, what do you do? But now we can do stuff. So it's exciting. Another kind of another trial that we did was with alucose, so AK002, which is anti-cyclic 8. So anti-cyclic 8 is expressed on eosinophils, mast cells, and basophils, and binding to it killed eosinophils but inhibited the activation of mast cells. They had a very promising phase 2 trial that showed that patient symptom scores decreased significantly when they were on treatment with AK002. But unfortunately, the phase 3 data from the top line read did not showed a significant improvement in the tissue eosinophil count, but not in patient reported outcomes. So because of this, they put all their kind of clinical trials on hold. So there was a lot of potential for this, but it seems that things have kind of slowed down a bit. We were supposed to do some subcutaneous trials with them in other disease states, and they've kind of put everything on hold for the time being. I think one of the reasons why is if you take all comers who have eosinophils in their gut, plus or minus, you're going to get some people who that's not really the cause of their disease state. So it's picking the right patients to do this. So I think that they're probably going to relook and kind of pick out who would be the most appropriate candidate to receive this type of drug. It's just such a rare disease. They were excited to get anybody with eosinophils in their GI tract and not really consider if they had really symptoms that were related to it. So if you take a typical IBS patient, they may have mast cells, they may have eosinophils in their stomach and their duodenum, but whether that's clinically relevant or not is not necessarily clear. And so if you eliminate them, they may not get clinically better. And so that's definitely a thing of concern. And so hopefully when they do their relook at it and kind of identify the better patients, they can have a more positive outcome, because it's a very interesting drug, and I'm hopeful, but it kind of fits a lot of the other anti-eosinophilic drugs that have not been very fruitful for any of this. So benralizumab and mepolizumab both have not shown to be of any significant improvement in patient symptoms. It makes histologically things better, but not necessarily for patients to feel better, which is really the most important bit. Yes, your tissues are gone, but if you still have dysphagia and impactions, that's not a positive result. All right, so
Dan, that study didn't include EOE, did it?
it did. So the second part, there was a second study, that the one we're doing, that has EOE, but they included everybody that had EGIT. So they have not done the analysis of the EOE trial in completion. So this was gastritis and duodenitis is what they kind of focused on for that trial. So the EOE is still kind of open at this point. So we have 2 active patients receiving it right now, and they're in their open label portion of things. Okay, and so the next area of research that we are just getting started in is chronic spontaneous urticaria. And so this was a nice kind of from a journal article published relatively recently, kind of showing all the different kind of targets and availability for the different aspects of it. And so over here in the corner here, there's omalizumab and ligelizumab, and ligelizumab has already shown to have pretty significant improvement, but doesn't seem to be that much better, at least in the phase 3 trial, compared to omalizumab. So that's going to be something that should be coming in the next year or two. And then there is also, kind of interesting enough, one of the more important kind of factors for mast cells to degranulate is through BTK, or Bruton's tyrosine kinase. And there are two investigating related thing, and we are doing the trial related to Lu-064, and which is going to be up and starting very soon. So it's called the Remix trial. And the Remix trial is open and recruiting. These are people 18-year-old and failed to be controlled on high dose H1 second generation antihistamines. People who can be part of this is people who have historically failed Xolair. So if they were on Xolair and didn't work for them and they've been off for a couple of months, I think it's like 3 months they have to be off, then they can participate in this as well. So it's a exciting trial that, especially with having an oral option for patients, I think would be very fruitful. So some of the, at least the safety thus far has been proven okay, but as many of the immunologists in the room know that BTK is also very important for other things, namely antibody for construction. So BTK is part of B cells, and that's how we know about BTK. It's also important for platelet aggregation and activation. So what does inhibition long-term with a BTK inhibitor will do? I don't know. Has lower potency than some of the other ones. And so there are other BTK inhibitors for cancer diagnosis. That's where a lot of the basis of this clinical trial is. It's an interesting thought. They're also going to be doing a kind of like an exploratory trial. We're looking at peanut allergy as well. So that's kind of exciting too. So we'll see how this goes and see if the side effects are tolerable and safe. All right, so just a quick the other things that we're doing at the research site, they're still open to recruiting. So AstraZeneca has an EGPA with benralizumab versus mepolizumab. And so this is patients who have confirmed EGPA but have never started an anti-IL-5, which is not a very common patient these days. So still looking for those patients. There's not very many in the United States, so we're still actively recruiting. We have 2, and we're a pretty high enroller for the trial. So if you have any patient like this who you're thinking about starting on mepolizumab, or if there's cost concerns related to it, well, this can be a way for them to get it. 100% of everybody gets a therapy of some type, whether it's benralizumab versus mepolizumab. There is no placebo. So it's a head-to-head comparison, not a placebo-controlled trial. GSK has something called the NIMBLE trial, and this is patients with moderate to severe asthma who are currently on mepolizumab and or benralizumab. And so patients are either randomized to continue taking their respective drugs or a new one. So this is a new investigational drug, which is a pegylated form of an anti-IL-5, which is supposed to last 6 months. So a twice-a-year type of injection instead of a monthly type of or a bi-monthly type of injection. And I like this trial mainly because it is there is no placebo. I think at this point in time, asthma trials that are placebo-controlled are unethical. With so many different treatment options, you shouldn't be waiting to get somebody into a trial. You should start them on a biologic if they need to be. And so biologics and any other futures trial should be a head-to-head comparison. That's what I think, but the FDA disagrees with me. And so they're continually doing placebo-controlled asthma trials, and I just won't do them. So this is a nice one if any of your patients are interested in doing this. And then we have a new Regeneron trial, which is for cat allergics. So this is an anti-FLD1 monoclonal antibody to reduce cat symptoms. And it's specifically for patients 18 above and must own a cat and not have gone through traditional cat immunotherapy. This is a special person who loves cats so much that they're willing to suffer through allergy symptoms with their cat in their presence. Most of the patients that we've gotten so far, the ones that we're kind of targeting, are going to be the patients who significant others have the cat. And so they love that person, and then the cat comes with that person, so they have to be with that person. And so this is a way for them to potentially get some therapy. It's placebo controlled. So if you have anybody who's like that, we would love to know about it. It's right now, because most of our cat allergics are also polyallergic to like pollens and other things, it's on hold until the end of the pollen season. So if you have anybody that you're thoughtful, that you think might be a candidate for this, just let us know. And then lastly, there's some potential things that are starting up soon that we're still under kind of consideration. There's potentially a sublingual peanut trial, kind of like a product that the guys over at I think in North Carolina or Duke kind of pioneered, and so they're kind of rolling out a phase 2, phase 3 trial for it. And then there's a new product that's looking at inducible urticaria, which is kind of a first of its type, specifically for cold and cholinergic urticaria. More to come soon. All right, so we have many wonderful sub-investigators that I definitely need to continue doing all the work that we're doing. Dr. Winroth, who's my co-director, Dr. Segezza, and Dr. Allman, who's been much helpful now that he is so-called taking time to do other things, including working with us, which is wonderful. Dr. Lasley, Dr. Tatum, Dr. Barant. And then I have a pair of managers, Lisa Miller and Trinity Smith, who've been critical in our revamp of everything. And then all my other staff, Robin, Joy, Mark, Maya, and Marissa, who've been a wonderful help. And then of course, all the study patients who give their time and effort to work with us and kind of give their time and their bodies to us to make for science. So it's been wonderful. So we have a couple more minutes if there's any more questions. I am open.
Dan, thanks very much. I've been around a long time, and in the old days when Asthma Inc. used to study the next generation antihistamine, it's amazing the quality of the science and you know how basic science advances your therapeutic design is brilliant. Along that line, that study with anti-fel D1 for cat allergy, has anybody thought about anti-ERA H2 to treat existing peanut allergy, or or a cocktail of antibodies to ERA H proteins?
I don't think anybody's ever done that, at least not in a kind of more organized type trial.
Is there something wrong with my thinking there? Would that be impossible? Or
I mean, potentially, I think it would be overwhelmed pretty readily. Just the amount of protein that would be involved in the absorption of it, it's rather different than just inhaling some pollen or some, because they've done, Regeneron's done this with like with birch allergy, and now they're doing with cat allergy. I just think it's the dose and the exposure. So I think you would have to have an enormous amount of antibody to be able to bind up all the protein that you would have. So I don't think it would be, I think you probably have to have like an IVIG type level of infusion to be able to handle that.
all right, well, we've got a big audience, over 40 people listening. Other questions? I've been wondering about such limited use of Palfordia. Is long-term viability of that product? I mean, they must not make money. Did you ever concern that you have people on it and then the company will go bust?
I have ways to kind of take people off of it and go into other things. So while they get started on that, so the exquisitely sensitive get started on that, I transition them a couple of months after they hit maintenance to something alternative. And I can do the same thing with a real product. It's just, it's a lot of art form to it. And so you just have to kind of, I've done it a lot to get to that point, but I don't have people on Palfordia long term. Usually the longest that they'll stay on it is about 3 months after they hit maintenance, and that's kind of the extent of it. So less than a year is the typical ask that I have for them. It's not pleasant. It's defatted, gritty sand is the description of it. Like, it's very gritty. It has all of the negative components of peanut, but not the positives. So it doesn't taste good. And these kids are often oral averse, so they just don't like it at all. So it's hard to mask.
That's even less good for the future of the company.
Well, they're under Nestle, so Nestle is a
big conglomerate. They can afford the loss.
Yeah, and So I don't think there's any issue. What I would like Nestle to do is come up with a gummy version of this or some sort of version that makes it taste great. If you can make vitamins taste awesome with gummies, why couldn't they do it with this? And so I have hopes that maybe Nestle will come up with a way to make this a much more palatable and more fun thing so that it could be a enjoyable process. It is the opposite of enjoyable. It's a good start. Don't get me wrong. It's better than nothing. And I love it that we have something. But it's where we start. It's generation one. It's a first version of something. So it's kind of where you kind of launch off from there.
All right, well, we got an open forum here. Speak up. Anybody at the U have a patient on Palfordia? Drew, do you know?
I don't think we've started anyone on Palfordia yet.
You know what the limitation is, Drew? Is it space? Is it?
Yeah, you know,
see.
with the Roosevelt Clinic, hopefully we'll start doing that, a more devoted peds clinic. But yeah, there's a lot of issues that go into it.
The room taking up a room can be challenging if you don't have very many. So if you do a conventional challenge and you do one of these things, it kind of kills a room for half the day. So you have to have plenty of room and space to be able to do this.
I know this is Vinod here, not to put and maybe Dilwar's on the call. So I know if I'd seen, welcome to Dilwar. I know Dilwar's new. I know, wasn't there, Dilwar was going to do some of the food challenges or some of these things in the area, because me and Arvin are the only challenges at the polyclinic, and certainly staffing is a big issue that, in terms of trying to do some of these things. So, and as detailed as you went through, Dan, with regards to the safety issues and trying to guide them through, I think that's probably the key part. So I don't know if anybody else, I know David, hate to see him, that is leaving, but it's we lost certainly a big loss here in the community. So it's certainly need for more people to do this, just that, staffing is a big part.
Yeah, I mean, we're going to try, once we get a system going, it's going to hopefully roll out to multiple of our clinics in Northwest. And so other people will start doing it and just integrating it. It's just figuring out the logistics of it right now. I have full confidence that I can train anybody to do this safely and kind of sort this out, but it's just the logistics background stuff that has become, that can be overwhelming. The company promises to help out and I'm holding them to it. And so as we because 1 is easy, 2 is easy, but what happens if you do 5, 10, and making sure that's all organized? And that's kind of where we're kind of learning to ramp out as well, and kind of coordinating all of the shipping and doing all this stuff and making sure the doses are there and doing all that stuff. So it's it's a process that we're kind of learning, and then how to integrate it with the practice, right? Yes.
Yeah, this is Dan. Can you hear me? This is
Hey,
Trevor.
Trev. Yeah, Trevor is doing it too. Yeah, so Trevor's doing it as well. So he's how many do you have now?
Yeah, so with Dan's support and guidance, I've taken on 6 patients across I'm in Eastern Washington, in Yakima and Richland. I have about 3 in each office. So again, smaller, more clinical, community practice locations. As Dan mentioned, I think that some of the biggest logistics is dealing with the pharmacy. I've had, you have to almost get a PA on every dose. They're very, so it's a lot of manpower hours for my staff to kind of get each dose approved and take it through and really stay on top of getting that shipped out. So a lot of the limitations of bringing patients on is just the workload that it requires from the staff standpoint to maintain the drug in clinic and get it shipped on time and get them ready for the UpDosing. So the product itself is nice because it kind of makes it a little bit cookie cutter for these patients. But that being said, every single one of these patients has my personal contact information. I manage them independently from my call group. I have them call me, and I've dealt with a lot of after hours questions and concerns, and almost every patient has had a symptom at some point. So it is a lot of both logistic work to manage these patients as well as just personal time. But it's something that, I wanted to bring to the side of the state, and with Dan's support have been able to do that, although small scale at this point.
Yeah, So just realize that too, is that they're going to have reactions. But a lot of that can be ameliorated with good education too. So a lot of times if you kind of have a good, and you reinforce it every time you see them for every updose, you can kind of head off a lot of the basic symptoms that they're having. So that a lot of it's like, can you take the dose today? And most of the time we'll say, because he's sick, well, no, skip today, that type of thing. So if you give them kind of permission structure to do that kind of stuff, a lot of them will be able to do this. So I have handouts and other things that I give them to give them guidance on things. So to help hopefully reduce the reactivity and the number of phone calls that are necessary and required.
And just, we need to wrap this up. Thank you very much. Again, just a couple of closing comments. For those who didn't know, there's a new faculty, Dilawar. I can't remember his last name right now, but developing a.
Coker. I said Coker, right?
Yeah, he's not on the line right now, but he's starting a pediatric clinic over at Roosevelt. One of my pet peeves has always been that our children's hospital doesn't offer a pediatric allergy clinic, which to me is absurd. So at least the university is taking that on in a small way. Second comment, I see David Naimi on the phone. Just a shout out to him. Nice to see you, Dave. And lastly, I'm starting to think about when we have sessions in person again. If you guys want to write to me, if you're comfortable with that, if we started doing that in the fall. I went to Symphony Hall last night for a concert for Ukraine, and it was nice to see 1,000 people in person in a room. And it'd be nice for our smaller community to actually be in a room together starting again. So I'd be happy to hear from people. Again, David, thank you for an excellent presentation.
Len,
Take care, everybody.
Dan. Okay, bye now.
Bye-bye.
Thanks, Dan. Good job.
Thanks.
David Naimi, good to see you.
Thanks for keeping these things going. It's really great. I'm just calling in from Naval Hospital Camp Pendleton in the San Diego area. It's been a couple of years since I've attended one of these, but Dan, really great talk. Very special thing we have going on up in the Pacific Northwest. So I'm glad to still be part of it. Thank you.
Thank you for joining, David.
Thanks.
Dan, what was the word of the day? I know you had it up front.
Vineyard.
Oh, that's right. The Petroni Vineyards. Got it.
Yeah.
Take care. Thanks, Dan.
Bye.